Hi everybody, we are going to have this training on non-fatal strangulation, which is a trauma topic, obviously. We're going to go through what this means, and this was a new subject for me in many aspects based on quite a few things that we're going to talk about: documentation, potential consequences of obtaining refusals, and honestly, just not being aware of some of the signs and symptoms that maybe I should have been aware of for a long time now. It's an interesting topic and training that's come out of Louisville, Kentucky. The medical director down there, Dr. Bill Smock, was at a training I was at recently, and he presented it to a room of, obviously, healthcare professionals. And it was pretty interesting to read everything that he had gone into and what they've really taken it and where they've really taken this non-fatal strangulation topic, and how it's helped police side, pre-hospital setting of us recognizing things, and then even into the hospital setting of getting the care that people need that they don't realize that they need sometimes. So we'll get into this. We'll talk about it. All this information is just a snapshot of what there is out there, honestly. And I will include that. Well, I did include that in the email. So here are our objectives. We're going to understand that there is a difference between choking and strangulation. And there's actually a lot more different ones that I'll briefly touch on when we get to that slide. But the big ones, and that I'm very guilty of, is saying that person was choked, and realistically that's not what happened. They were strangled, and we need to get into the habit of realizing that and what the difference is, and we'll talk about the difference. We're going to understand why it is so important to recognize that someone was strangled non-fatally, and to document that appropriately, and to look out for the signs and symptoms that maybe we've always caught on to all these years. We just didn't realize the association of the danger that it could present down the road. We're going to look at some of the signs and symptoms, and then we're going to need to talk about some documentation. Pretty brief. So we'll start with some statistics. All these statistics are from that Strangulation Institute, and they've taken a hard look at all the numbers of not just people who, and obviously the big one for us is domestic violence, but they've taken a hard look at the numbers, and not just from domestic violence, but police shootings over the years, marital abuse, terrorists, people who have a history of doing bad things, and what are their predictors. And one of their big predictors that they found is they like to put their hands on people's throats. And knowing that, they've been able to identify people earlier as someone who is capable and has the will to do something much more catastrophic to multiple people, as opposed to it being a domestic violence situation. Because domestic violence is not good, but it's one person as compared to if they take these people and they link them to bigger casualty events, such as in the bottom of the slide there you see Pulse nightclub, the Fort Lauderdale airport, the First Baptist Church in Texas, and then the Boston Marathon bombing. All these folks had documented history of strangling an intimate partner. That's pretty telling. I don't know what the number is for that specifically, but I do know that they are working on numbers now for police officer shootings, and they don't have the data out yet. But one that he threw out there that's come up so far is 75% of police shootings were from people who had strangled someone in the past, and it had been documented. So it shows us that these people are not so much for us, for the healthcare side, but it shows the police. And if we hear that information, maybe we should be telling the police these, because should be a red flag for them and for us to know that we really need to do our due diligence for the person who was hurt to get them out of that situation. So to start with the stats, 1 in 4 women are going to experience intimate partner violence. A woman who survives non-fatal strangulation incident from an intimate partner is 750% more likely to be killed by the offender. That killing usually occurs with a gun. 68 to 80% of the women who will experience intimate partner violence will be victims of non-fatal strangulation. That's a pretty high percentage of people who are experiencing domestic abuse. Now, you notice we're talking about women quite a bit. In all their studies, high 90% of the folks who are doing this are men. So the folks that like to strangle people are more often than not are male perpetrators. And then our patients are females typically. Not always, but more often than not, what the data shows, that's what we're finding. So here's a big one here in the middle. On average, only 50% of non-fatal strangulation victims have visible injuries. So 50% of the folks that we're going to go on for what we typically dispatch for is a domestic violence, only 50% of those folks are going to show visible injuries, but they can have damage internally, specifically to their hyoid bone, carotids, and any of the structures there around those two major ones. So that leads into a couple things, that domestic abuse, deputies show up, they don't find any injuries on this person because they were called, it's a police issue, it's a domestic violence, and they are not trained to recognize these symptoms, and then they don't see any injuries, so they don't see the need to call us. So and that's something that we really can't affect right now, and maybe down the road as we learn more about this, maybe we can help our deputies out and become a little more educated on this and maybe impact our dispatch side of things a little bit to maybe where we start getting dispatched on these automatically. But, so that's the first hurdle we have to jump over. And then, if we read a little bit further, only 50% of the remaining victims actually have injuries prominent enough to photograph. So, that's not a lot. We're only looking at 15% of all victims have any sort of injuries that will show up enough for a police detective to take a picture of, or a doctor to say, oh, yep, you've definitely been strangled. Everyone else, they're just not there, or they're very minor. And the ones that we can see are pretty obvious, right? We know that they probably have some internal damage. It's the ones that we can't see. And unfortunately, that seems to be the large majority of them. So, we already talked about this bottom bullet point here. Folks who strangle tend to have a propensity to have it in them to do something much worse than strangle one person. They really want to do a lot of damage to many people, which is a scary thought. But knowing that, it gives us hopefully the heads up that we can stop these people from ever doing anything such as any of these awful events here. So we're going to talk about some definitions real quick. These are pretty straightforward. So these are the 4 big ones that we'll probably talk about the most when we're on scenes, when we're talking about documentation, and then throughout this lecture. These are the 4 big ones. There's other ones though. So strangulation, external pressure to the neck by any means. And it's important to understand that external pressure is obstructing blood flow and or airflow to the neck. That is the difference. It is a form of asphyxia, but it is pressure. Strangulation is the external pressure from the outside that is causing their issue. That's obstructing. More often than not, it is blood flow that's being obstructed. Sometimes it's airflow, but we're going to talk about the hyoid bone and hyoid injuries in a little bit. And those are pretty easy to break in what sits right there. So that's strangulation. So if we talk about non-fatal strangulation here, someone has external pressure onto their neck by any means that obstructs blood flow or airflow, and they didn't die. Okay? They survived the event because the perpetrator, the attacker, had a moment of clarity. The victim fought back. Someone intervened. It doesn't matter. They survived. But what happened during those moments of strangulation? And we're going to talk about that specifically, what happens and why it's so important for us to really understand the need to do a good assessment, and then maybe be a little bit paranoid for these people, because they're probably not going to be paranoid. They're probably, unfortunately, numb to this, used to this. Multiple people in abusive relationships tend to stick around because they feel like they're needed, or they feel like they can change them maybe. But we'll talk about some of the hidden injuries in a minute with the non-fatal strangulation. And choking. We're going to talk about the difference between choking and strangulation on the next slide, but the definition of choking, is a partial or complete obstruction of the airway, often due to an object or foreign body. That is choking. So you can probably see now why we shouldn't be documenting in some of our narratives like the patient was choked. Well, that's not true unless, of course, the perpetrator or the attacker opened their mouth and shoved a steak down there. Then they were choked. More often than not, if there is hands put around their neck, that's strangulation. That is what we need to document it as. This person was strangled. And it is a whole different subset of injuries and a different type of asphyxia compared to choking than just eating dinner and then you try to take too big of a piece. There's a big difference of those injuries and those pathways. Asphyxiation is the state or process of being deprived of oxygen. So anything that causes them to not get oxygen is asphyxiation. So if you cut off blood flow and they're not getting oxygen to their brain, they're asphyxiated. If they choke on a piece of food, they're asphyxiated. If they're strangled and they have their airflow cut off, they're asphyxiated. So asphyxiation is kind of the big one that oversees all of them. And then when we get down into the specifics, we can identify what actually happened with these three. Hopefully that makes sense. So some others that you may or may not see, and I'm not sure exactly where Butler County is with all this stuff. It's not all that new, but it's I had never heard of it, and so I'm not sure if it's made its way here yet. I'm sure to some people it has. But you may hear some deputies say, or detectives probably more likely, that we're talking about a manual strangulation, which is the person literally using their hands or legs. They wrap their leg around their throat. They're manually using their body to strangle somebody. Ligature strangulation is the suspect is using a shoelace, a rope, a chain. They're using something to strangle them with. And then a form of strangulation that some of us have probably been on is hanging. That is a form of strangulation. Obviously, that is someone doing it to themselves, using their body weight with some sort of device to wrap around their neck. There's quite a bit more, and you can find basically as many as you want, as much information on this as you want on this strangulationtraininginstitute.com. It's a pretty in-depth site, and they've done a lot of research. It's very impressive. All comes out of Louisville. So strangulation versus choking. So to break it down just a little bit further and to give you a visual, this is what we're looking at. So in strangulation, external pressure is applied. Choking, there is no extra force applied. There is something blocking the airway, usually from the inside. That's choking. Strangulation obstructs blood and or air. Choking only obstructs air. Strangulation is a form of asphyxia, but requires external force. Choking is also a form of asphyxia, but it requires an object. So those are our big differences that we need to be able to distinguish and then document appropriately. Let's do some anatomy real quick. So if we look at anatomy, we have the picture of the average human neck here. And we look at things that someone wraps their arm around, what's being damaged. So we have the carotid artery, obviously. Okay, it's coming up from the body, from the heart. We're feeding our brain. Brain is very good. We need to feed that. It's got to be fed. Got one on each side. Perfect. Blue is our jugulars. I'm sure we've all started an IV in those. Pretty straightforward. Those are our vessels. Everyone probably knows where those are. We all learned that in EMT school. Just check for a pulse, so on and so forth. If you advance into medic school, you learn that external jugular is a great place to start an IV. When someone is hypovolemic, it's a great place. As we move in, this should also look familiar. Hyoid bone, right here. Thyroid cartilage. Your cricoid. And then your tracheal rings. So all these things are structures that can be damaged. So if we apply external pressure to the neck here, and depending on how it's being applied, because of, I'm sure the person being choked probably doesn't want to be. There's a reason they're being strangled. A fight has ensued. Something has gone wrong. They're going to fight back. If we apply pressure to the vessels, we're occluding blood flow. If it happens bilaterally, we don't know. But what we do know is that these are pretty easily damaged. And there's a picture later on in the presentation when we're talking about the signs and symptoms and why people need to go to the hospital for carotid dissections. That's the big one we're worried about, is we're getting pressure. These are not far from the surface of the skin, and when we occlude those, or now we're occluding them and then someone's struggling and moving from side to side, holding them still, and now we're jerking and yanking and maybe damaging those vessels themselves. That's a problem. Not only are we causing a potential anoxic injury to the brain because we're cutting off blood supply and any oxygen getting to the brain through blood flow, we are now potentially damaging the highways that take that oxygen to the brain. Multiple problems there, right? So then if we look here specifically at 3 and 4, the hyoid bone, according to all their studies, is it only takes about 8 pounds of pressure to break that thing. A lot of times what you'll see with that kind of injury, the signs and symptoms is constant coughing, like they excuse me and they cough, excuse me and they cough. They're constantly swallowing hard because they feel like they don't have enough room in their oropharynx. Or maybe they're just telling you like there's something wrong, I can't breathe, but all their saturations are fine, because they are getting enough. It just feels like they can't because, well, the hyoid bone's broke. And then right below the hyoid, we have the thyroid cartilage that if this gets broke, then this has probably been affected. And the thyroid cartilage obviously is called the thyroid cartilage because our thyroid gland sits there. And we'll talk about the reason it's so important to understand our strangulation patients as association to if we have very visible marks here or no visible marks and we have someone presenting like they're having a thyroid storm, this is why. And we know why thyroid storms happen. It's from trauma typically. Usually it's trauma to the body and they have a pre-existing condition, not direct attack to their thyroid, but in this case, the perfectly healthy person could present with those signs and symptoms because the thyroid gland sits right there. So, here's our assessment. This is what we are This is an algorithm that they have for their ER docs, basically to start documenting consistently across all the different doctors of anyone who comes in with domestic abuse, potential strangulation, they were choked, quote unquote. They started trying to be consistent with everything that they're talking about. That way, they can start tracking these numbers appropriately. And this is a part of their algorithm. Now, the algorithm is pretty big, so obviously I didn't include it in here. I just took out a part where if we were assessing someone, which we do, and we're bringing them into the ER, this is maybe the assessment that we're all looking for and that we are already probably picking up on, but are we realizing that this is a part of a strangulation and we're not just calling it a trauma? So a couple key things to take off of this, all these words here, is if we have signs. So symptoms are something that we find when we are assessing our patient based on any number of tools that we use: SpO2, blood pressure, heart rate. We listen to lung sounds. We find those signs are typically what we see on our patients or what we're able to appreciate by touch or sight. So when we see stuff, remember, if we think back to the statistics, only 15% of injuries are actually visible on our victims. If we see signs, assume it's more severe, because it probably is. Even if they're fine, they're up and talking to you, it is the moments, hours, days, and even weeks and months down the road that they are still in danger, specifically of carotid dissection. That is the one that is hitting people up to months later, where they have a major issue, whether it be a blood clot or stroke. It separates completely and they bleed out. Lots of bad things can happen with that, obviously. So signs equals more severe. Just assume that, even if they seem to be fine. Symptoms, let's take a good assessment of our patient. Make sure we're doing all the right things as far as uncovering their clothes, getting a look at all their chest, making sure that we are looking for defensive wounds on maybe the perp, and then correlate those back to our victim, and then make sure we don't leave anything out for our vic. So, foggy presentation here. So what they found is a lot of people say, yeah, they strangled me, or they choked me, typically is what they say. We just have to interpret it for them. They choked me. I was, fighting back, and we were in the kitchen, and then I woke up in the living room. Maybe they were only out for 15 seconds, whatever it happened to be, but they wake up and then they say, well, what signs and symptoms do you have? I just feel foggy, I'm really nervous, I'm all amped up over the fight. I'm fine. I'm just, I need a little bit to calm down, and everything will return to normal. I'll be okay, And we've probably all been there when we've done something strenuous, sports activities, car accidents, whatever that we've been involved in throughout our lives, where we get that sudden adrenaline dump, and we're like, whew, we're amped, we're going. Well, this person may have that going on, as well as they had blood loss to the hippocampus, which doesn't take much. So if they have blood loss to the brain, and we're going to talk about anoxic injuries a little further later, but that is an anoxic injury, or the beginning of one. And the foggy presentation is a good sign or symptom that they can tell you that, maybe they did lose some blood loss because they were strangled, because they had complete loss of blood flow to their brain. So the hippocampus is the part of the brain that deals with learning and memory. So if it's more than just foggy, like I don't remember, or I can't tell you, or they're struggling remembering like their neighbor's name, stuff like that. That's a learning and memory insult to the brain. That non-fatal strangulation has now affected their brain pretty severely. And don't discount that maybe they're just protecting the perp. We should probably take that pretty serious. Petechiae, we're going to talk about quite a bit. Petechiae is one of the most obvious signs that we could see in our patients across multiple parts of their body, specifically the face. And petechiae is the bursting of blood vessels. So if we take a look at, this is something else from the website. So we're taking a look at all these signs and symptoms. We have our patient here. There's our petechiae. Bloodshot eyes. This is all like strenuous, like pressure that they're exerting because they're fighting. They don't like to be choked, obviously. And we translate that for them from choking to strangulation. We have these show up. These are our severe patients. These are the ones that we know they struggled hard against this. And now we need to have a higher index of suspicion that this person not only has stuff going on out here, obviously, but more than likely on the inside also. So we talked about loss of memory. Remember, that's an anoxic insult to the hippocampus, which is a part of the brain. Not good. Behavioral changes. Typically, that is a pretty severe anoxic insult. That takes a while to take place. However, if we have a behavioral change because brother, sister, neighbor, whatever, says, yeah, they just don't, over the last couple months, they've not been themselves. Abusers tend to abuse the abusees more than once before finally it escalates and one of them ends it for good. So that behavior change may be a history of multiple strangulations. Loss of sensation, extremity weakness, difficulty speaking. So that's that hyoid bone that's been cracked or broken. Or maybe those cricoid cartilage tracheal rings are damaged. Not affecting our SpO2 saturation. Not affecting their ability to have good clear lung sounds. But they have damage, and that's an issue. Now, if we have a really bad sign or symptom, it would be subcutaneous emphysema, right? Like, ooh, that's not good. Probably not the case very often, but if we have this difficulty speaking, that is a sign that they have some traumatic injury to that area. Fainting, urination, defecation, all three of those should sound pretty familiar from when we're talking about our seizures, right? It doesn't take much, and I have it in one of the later slides, but I think it's 15 seconds is all it takes of complete blood flow to cause an anoxic injury enough to cause urination and a seizure. So if we have a witness that says, they seized. Why'd they seize? Well, he was choking, strangling her. Oh, well, should we really debate the fact which came first, the seizure or the strangulation? Let's assume the strangulation. Seizure's pretty easy to fix. Strangulation, there's damage in there that we can't fix. They have to have a surgeon help them out down the road. So, dizziness and headaches, obviously, that should equal blood loss to the brain. So if we take a look at our eyes and eyelids, so eyelids are pretty vascular. Eyes, the whole face and head really is very vascular. Vision changes are not good. That's an insult to this very sensitive area. And then this looks a lot like a stroke symptom, right? Droopy eyelid. And then we have the blood vessels from all the pressure being exerted to fight. And then obviously it didn't work out too well for them. So this should be a pretty obvious sign for them. Scalp, petechiae again. Here's one of those defensive ones. So bald spots. Don't discount defensive wounds on the perp too. Might give you a clue where to look on our Vic. Just make sure that we're doing our due diligence at looking at both of them. If they have a bald spot, don't just assume that they're into some weird new hairstyle. It's probably from the ensuing fight. I know we're talking about non-fatal strangulation specifically to external pressure to the neck, but we can't ever discount the fact that it was a very clean strangulation, right? They may have been tossed around, hit against the wall, hit against other pieces of furniture. Maybe they used a frying pan, Tom and Jerry style. Who knows? Can't discount that stuff to where we are just focusing on their airway and these carotids. We got to focus on everything. Tendinitis, ringing in the ears, petechiae, bruising behind the ear, and bleeding in the ear. These are all signs and symptoms that they could have been traumatically affected and strangled. So we move down the face a little bit here. We're going to take a look at the rest of the area. This is probably the part that we will focus in on the most because they were strangled. And this is where we may or may not see the majority of our injuries. So if we look at the rest of the face, these are all very similar to what we've already read. We're looking at our mouth. Pretty straightforward, right? May have had their lip, may have been punched, may have hit their face on something, who knows? But the big one is the internal petechiae. Just like when you're checking someone's color, because for whatever reason they're wearing lots of makeup and you want to see, if they're cyanotic and you can't tell from the exterior, you can pull their lip back and look on the inside. Same thing there. Internal petechiae could be a dead giveaway that they had some pressure exerted on them and now they have popped some blood vessels. Chest, we're going to do neck in a minute. Chest, pretty straightforward. Defensive marks, attacks, they're probably not going to get a firm hold on the first time when they go to strangle this person, so look for those wounds where it was just a little sloppy. There's a ligature mark where they used a shoelace, whatever else they happened to get their hands on, rope. We have finger marks, and then scratches. Who knows how long it took them to get there. So if we take a look at the neck there, remember only 15% of the victims are going to have this, to where we're going to walk up and be like, okay, this person was definitely strangled. It's quite obvious because, well, there's that person's gigantic mitt on their neck. Not very often do we see that because it's not very easy to hold on to someone's neck, especially if they're fighting, to get away. Who knows what else happened in the meantime to intervene with that. Breathing changes, obviously difficulty breathing, respiratory distress, unable to breathe. Those should be an indicator that somewhere in here was affected pretty dramatically, that we have damage. That's not good. Okay, especially if you have a strong indication and they tell you that this is where it happened. Assume that your trachea, your hyoid, something in there is damaged. They need to be seen. Voice, throat changes. So raspy or hoarse voice is a very common sign, according to Dr. Smock, that more often than not you'll show up and they'll have that kind of exasperated, out-of-breath look. They're probably a mess from just being in a fight. They're worried about whoever else is in the house and they broke my favorite lamp. But they're very raspy and very hoarse. So that is a strong indication that they have damaged their vocal cords. So that's a pretty deep insult to affect something so far into their body, specifically the structures of their neck, that they need to be checked out, because if there's damage that far, there's probably damage to their blood vessels. Unable to speak at all is a real problem. That means we probably either have irreversible damage to those vocal cords or they're swollen so far that we're going to start having trouble breathing issues real soon. Painful swallowing, that I talked about, that constantly clearing their throat. They're constantly just coughing. They're drooling. Their throats just feel sore. Maybe they have some stridor. All these are signs and symptoms that somewhere in there something happened. Now, unless they're like a 20-pack smoker a day, do your due diligence, ask your questions. But if you have any of these, it's always better to err on the side of caution, because these are injuries that we can't really treat, but we can recognize and ensure they get the follow-up care that they require. So anoxic brain injuries and thyroid issues. So we talked about a lot of stuff there. And if we're talking about specifically anoxic brain injuries, an anoxic insult is where we have complete loss of blood flow to the brain. The brain is getting zero oxygen. So when that happens, we can start timing. And what they found is 15 seconds of that or greater, we have urinary incontinence, and witnesses have stated a seizure. Now, they said the seizure stated 60 seconds. I don't discount the data that they have, but I do discount the witnesses somewhat, because when you throw someone in a situation like that, I think it's hard not to get the time incorrect, because there's a lot happening. Maybe your friend's being choked. There's a witness. You don't know this person. You don't know what's happening. Who's the victim? Who's the perp? A lot of stuff going on. I believe this number, though. 15 seconds isn't a long time. Urinary incontinence, that one's hard to fake. So if we're thinking about that, and that should be our launching point of this person has at least 15 seconds of zero oxygen delivery to the brain, we have an issue. So if we add 45 seconds of that and we jump over here to our anoxic clock and we hit 1 minute, we have begun to kill brain cells. They don't come back. They're gone forever. So this might be our person that has those behavioral changes. If they have a minute of being strangled where there's zero oxygen delivery to the brain, these might be our people who are very similar to our stroke patients or our TBI survivors. They have that behavioral change, that sudden alteration in the way that they act from day to day, where they went down as one person, and when they woke back up and got reoxygenated, they're slightly off. That's probably going to be them. If this person's really committed and they're hitting 3 minutes, we have serious brain damage. That's commitment. That person is going to be irreversibly damaged for life. 10 minutes, we've hit unlikely recovery. You notice 3 to 10 minutes, that's a 7-minute window in there. And that's probably because tracking these exact data points is very tough. When they have these, this is the best data we can get out of this. But I'm not sure too many people are volunteering to be strangled with the end goal of obtaining an anoxic injury for 5.5 minutes to see what happens. This is the data that they have, and this is what they're showing. Pretty surreal. It's not good. 15 minutes, recovery is virtually impossible. Those are anoxic brain injuries. Anoxic brain injuries for us don't happen all that often. More often than not, it happens during a true choking, when we have someone choke on a food and then they are no longer converting oxygen into their bloodstream and shuffling it up to the brain. That's typically where we have our anoxic brain injuries. Strangulation, probably not the one that we see more often than not, but there you go. There's your numbers, and this is why things happen to our patients when we see them. So in that same general area, not talking about our blood vessels, and we're talking about the hyoid and thyroid cartilage, that area on the upper part of midline trach, we have the thyroid gland. Thyroid gland is pretty important, obviously, but if we have a direct insult to that, and they don't have that pre-existing condition, they could be hypertensive and tachycardic among other signs and symptoms, and the insult, the attack, the domestic event happened 45 minutes ago, and their high blood pressure, their blood pressure is still high, and they're still tachycardic. Maybe they're saying, I'm coughing a lot, I feel like I can't breathe, or a 2-sat's fine. they may be in the beginnings of a thyroid storm. Uncontrolled thyroid storm is bad, regardless whether they have a pre-existing condition or not. This needs to be treated. And this should be in our differential for someone who has domestic violence exhibiting signs and symptoms, characteristics of a damaged thyroid gland. So assessment. So our assessment doesn't really change as far as physically. We need to be very good about what we're doing when we're talking about this. Maintain their privacy. Make sure we have people around. Make sure they feel comfortable, because likely they've just had their world rocked a little bit. So we need to keep that in mind. So psychologically maintain some stabilization with the crew and the environment and the patient. And then mentally make sure that they're good to go. Make sure you're caring for those needs as well. And then physically, your physical assessment should be a trauma assessment. We need to look at everything. We need to look at their chest. We need to look at their back. What happened to your legs? Did you hit anything? Make sure we're doing a good job. We don't want to be the ones that miss something because we're so focused on this person was strangled, which is very important. I'm glad that we are starting to do that, but we need to also think about some of the other injuries that could have happened in the same time frame as the strangulation. So when we are getting to the point where we've really done our physical assessment and now we're going to start talking to the patient and trying to figure out exactly what happened, let's ask some of these. So these are some of the questions that the Strangulation Training Institute puts on their ER cards for their doctors to ask, because they want them to be pretty open-ended. They don't want to lead them down, which is really no different than what we do now, honestly. We try not to lead people down the path, like, sir, can you describe your chest pain? Is it crushing and substernal? Is it a 7 out of 10? Yeah. So we don't do that, right? This should be no different. It's just a little different because we don't do it a whole lot. Partly because we don't go on all domestic violence, and partly because we just don't have this a whole lot, maybe. I'm sure now, having had this training and looking back, I know for sure that I've missed a non-fatal strangulation that I had to have, just looking back. And hopefully this is the point where we can focus in and not miss these, which is a good thing, I think. So open-ended questions. Our victim may try to protect our perp. And it's not our perp. It kind of is. And not in the sense that we want to catch them, because we're not police. That's not what we do. However, we do have an obligation to the residents of Liberty. And a part of that obligation is to make sure, knowing what we know now, that this perpetrator who just strangled our patient should, in our mind, and hopefully the deputy's mind, automatically be someone who has it in them to do something like this to lots of people. That's important information. And by us asking the right questions and maybe trying to nail this guy down through our documentation, because this person truly was strangled, maybe we save the next one, who is another township resident. Who knows? So ask them things like, what do you remember? Just let them talk. Was any pressure applied to your neck? Don't ask them if they were choked. Ask them, was there any pressure? Yes? Okay. How was the pressure applied? Or, and if they say, well, with their hands or, forcefully, okay, what did they use to apply pressure? And then start leading them down, like, ask them very open-ended questions about how, why, where, what, and make sure that they are explaining to you exactly what they remember. And remember that if they say, I don't remember, or everything's just so foggy, that's a good thing to know. And that is a good thing to document, because that means they had an insult to their hippocampus. Audio or visual impairments, anoxic brain injury. Think anoxic brain injury if they have that. Something has happened somewhere in there that all those two things didn't get the blood that they needed, and now they're a little bit impaired. Comprehending what is happening is not good. And then difficulty swallowing, is like we've talked about previously, is that hyoid bone fracture. So when you're thinking about your assessment, it's a little, I don't know, at least to me, when I was thinking about this, I was like, man, this is just a strange way to think about an assessment of a trauma patient, is really what we're talking about here. But I thought it was good stuff. So here's a carotid dissection. So they have that insult, that external pressure applied to their neck through whatever means, and it was enough, or the patient twisted, the perpetrator twisted, it was a rough fight, and now we have damage. So carotid dissections, which this should look kind of familiar. One of the scary things we worry about is tearing, chest pain that radiates to our back, or belly pain, masses, stuff like that. We're talking about an aortic, abdominal aortic dissection, or a thoracic aortic aneurysm. Same thing. We have blood entering between the layers of our vessels. Builds up, builds up, builds up, builds up, builds up, builds up. So this can keep building, ballooning out, and then this can start dissecting and running down the length of the vessel, which will tear it wider and wider and wider, which obviously can cause issues with volume, pain, tearing, but also you'll see this here. This is all clotting off, right? Because these are all blood vessels. They're doing their thing. Wow, there's space here that's not supposed to be here. Let's enact our clotting cascade, do our thing, and try to seal this up. And it ends up making these little things that hang out into the vasculature. They break off sometimes. Stroke, PE, DVT, other things like that. In this case, we know this is carotid. It's going to end up being a stroke. Unless the body eats it, of course. But if they break one off big enough, down the road, this could be 3 weeks, a month, 6 months later, where this finally happens because they have another traumatic injury, because they're with the abuser still. And it happens again. And we didn't catch it the first time, or the police never even called us in the first place. Because they just don't, it's not their fault. They don't know. This is what we're worried about. This is the fear right here. A carotid dissection that happens and then manifests hours, days, weeks, months later. This will kill people or damage them for the rest of their lives to where they have to manage it. So this is a carotid of someone who did not go to the ER after a domestic assault. They felt fine. If I'm remembering correctly, this one was one of the ones that said, I just feel foggy, I'll be fine, no big deal. I'm not sure what happened to the perp, but 12 hours later, probably less than 12 hours later, they got worse, ended up going to the ER. This was 12 hours from the time of the incident, roughly, to them getting a look at this. It took 12 hours to clot that thing off based on the dissection that they had. It's a lot of blood, and that completely cut off one part of the brain at least, unless it was bilateral. And then we're looking at a true anoxic injury, which is probably, if this person's dead, which I'm guessing they are, is what they died from. Now, could us taking that person out of us learning all this today save them? Maybe. Maybe not. I don't know. But I do know that it would be the right thing to do for us to take them and then tell the ER doc exactly what we found. let the ER doc talk to the patient, and then maybe they end up doing a scan of the neck and be like, oh yes, we do have a mild dissection. Apparently they're pretty easy to spot. They have on the website, they have tons and tons and tons of scans of necks that show dissections. So apparently they're pretty easily to notice. And the follow-up treatment for a lot of that is following up with the doctor or a doctor. And then they get put on blood thinners to help mitigate any of the after effects of that. And then obviously they then begin to remove those people from those situations by constantly educating them about the dangers of staying in that situation. Now they have true evidence that this person was damaged by someone, and that helps with the police side of things of maybe keeping that person locked up a little bit longer. Again, that is not the point of the training, is that we're trying to lock people up longer. The point of the training is to recognize this, hopefully. I apologize for the phone there. So if we continue on here, I know we've really focused in on domestic violence, and that is honestly probably where we're going to see the vast majority of this. But it's not exclusive. We have martial arts academies in this neighborhood. We have people in our houses that practice martial arts, especially now with people being confined to their homes more often than not. Maybe they're practicing at home more, and they're getting their family members involved, which is great. Awesome exercise. However, if someone, maybe a little inexperienced, gets a little over aggressive, rear naked choke to the neck can cause this. It could cause damage to our airways or our carotid vasculature. Just realize we're not talking about just when we're getting dispatched to one of our medics going to assist PD for domestic violence. And then we get there and, you guys can go home. No big deal. We got this. Or, we get to someone's house and they had some kids over, or, their kids were playing the pass out game. Or we have wrestling meets and practices once they start back up again at the high school. Butler Tech Police Academy. These are all places where we may not get called for domestic violence because it's not domestic violence. We're talking about an injury, a trauma. Non-fatal strangulation is a trauma. We just happen to have a very good snapshot of data from domestic violence specifically. Repeat offenders, from what is the easiest to find, are mixed martial arts. Honestly, these folks, they train hard, and there have been, I found a ton of reports and articles of amateur mixed martial artists who either died or had strokes. Lots and lots of. It's an interesting read. You should just Google it. Mixed martial arts with. You can try the strangulation. You're probably not going to find a lot. I had to get creative by basically looking for choking, stroke, MMA, TBIs, stuff like that. It was pretty. I didn't think there would be that many, and there was a lot more than I expected. So, but multiple anoxic injuries, like these folks, boxers are good for them. They present like TBIs, PTSD, mood swings. They're angry, memory loss. They may present with those more long-term signs and symptoms that we talked about, as opposed to some of the more acute ones. They'll probably have the acute ones too, if it's bad enough. But seeing those more long-term ones may be an indication that they have multiple, or they have had one very recently within the last couple months, which is a problem. This was something that they have, since coming out with this, they have been able to speak with different police agencies, and the list is has grown a decent amount. But these agencies are banning or limiting vascular neck restraints, and when it is used, it's considered a use of lethal and deadly force because of this, because of these studies by Dr. Smuck, and how he's been trying to basically, his main goal has been to link these strangulation cases to cop killers. He wants to be able to identify cop killers before the cops are ever killed. And what he found through this is just how dangerous some of this stuff was. So they have actually, they've done more with their policies and procedures other than just identifying these cop killers. They're able to say, like, yeah, this is going to be deadly force because of this. And they've changed their training programs as well. So documentation, getting back to, kind of the EMS side of things, we need to document patients' quotes. So when we ask those open-ended questions like, did someone apply pressure to your neck? Yes, they used their hands and it was here and here, and then describe that. Document those specific weird signs and symptoms that we talked about. Difficulty swallowing is probably something I've never, ever, ever put in an EMS PCR, but maybe the time has come. Incontinence, I feel like we do a decent amount, but typically that is for our patients who are either unable to control it because of other things. They've had surgery, cancer, whatever has happened. Usually not because of a traumatic injury, specifically strangulation. But that's something we need to document that. Feeling foggy, not something I would probably ever document before now. Raspy voice, clearing of the throat. I always assume maybe that's just them. Maybe they smoke a lot. Maybe they got a cough. Who knows? As weird as that stuff might be, in the moment, those could be indicators that something else happened that we're just not able to see and really appreciate. So we need to document that. Document the open-ended questions that you asked with the answers. So this is where we are really starting to narrow in on the patient's basically ability to remember these things, because a lot of these questions, especially if this becomes more widespread, is going to get asked again, and then they compare what we asked to what they asked, and even if they're similar, then they know that, well, their memory is getting worse, or why are they lying, or why is this answer different now? What has changed? Are they having less blood flow to their brain now because they have a carotid dissection? That's trackable as long as we document our questions. Do not document that the patient was choked if strangulation was suspected. So choking really is only reserved for if they truly choked. If they put something in their mouth, couldn't get it out, and it blocked their air supply, they choked. Strangulation needs to be very separate. Now, if for some weird reason they choked and were strangled, to document that. But those two words should not be in a PCR together very often, unless some super weird circumstances are happening. Document anything that is visible that you see upon your assessment. So in those 15% of cases where they do have visible injuries, we need to document exactly, because what may happen in an hour or so, more injuries become visible. So then same thing with that, documenting our questions and their answers. They can document their memory and their neurological state. We can also document their physical state and how their injuries are developing, and maybe they can track what's going to happen next to them. Summary, I hope after this hour that we are able to distinguish between choking and strangulation. They are very, very different. And I'm very guilty of using the two words interchangeably. And I think it was a nice wake-up call for me, so hopefully it has been for you. Just because we do not see an injury does not mean there is not one. In fact, we should be assuming that they have an injury if they were strangled, non-fatally strangled, that there is an injury that we can't see. The data just shows that more often than not, they're not going to present with any signs on the exterior of their body that show us like, oh yeah, this person was definitely strangled. It's just not the case. These folks need to be seen by radiology, realistically. Docs are great, nurses are great, we are great. But radiology is really where this person needs to go. They need to be seen. And you need to do a good job of being a good advocate of your patient to the doc. If you come in and you just happen to get that night shift crew who's like just not feeling it. You know, they're overworked, underpaid, and they've been super busy tonight. And like, no, this person was definitely strangled. Here's why. I suspect that maybe this person has damage to their carotids. Even if you're wrong, you did the right thing by making sure they got a picture of that neck. And that this person's not going to die in 3 weeks from a stroke or some sort of complete occlusion and an anoxic injury. 15 seconds should be the kind of the time of starting the clock for you. Of 15 seconds and greater is where bad things begin to happen to the body for an anoxic injury. Because anything beyond 15 seconds, we're looking at, it kind of escalates into places where 15 seconds is recoverable. 30 seconds is recoverable. We hit that 60-second mark, we're going to start seeing potentially long-term signs and symptoms that this person's going to suffer from. Even if it's just behavioral changes for a week, a month. It doesn't matter. That is long-term, you know. And who knows how long it'll last. Just depends. Because it's very hard to tell exactly how much pressure was applied and if was the pressure consistent. So 15 seconds and recognizing that urinary incontinence, potential seizure, that should be our benchmark. Like, okay, they have definitely had complete occlusion to their blood supply to their brain. So just mark that one in your head. The last thing is good detailed documentation. Hopefully throughout this, you've had the same realization that I did, that I probably did not do my due diligence on my previous runs with these folks, and I have no doubt in my mind that I probably didn't document appropriately on at least multiple runs because I just didn't know. I was ignorant, and hopefully now that seeing this has helped you as much as it's helped me. So I appreciate it, your time and your effort with all these. I really hope they're helpful. I've heard good things, and if there's anything that you guys have to make this better, please, as always, let us know. Shoot me an email. If there's a topic you want to hear that you think this would be a great format for this, we're all ears, and we are doing this to make sure that not only are we keeping up on our CEUs, but it's an interactive way for us to sit down as crews and talk about just different things. Because I know when we've sat down as a crew here, it sparked other conversations. So please feel free to let us know what'll make this better. Thanks.